Advanced Pharmacology Study Notes, Men's Health. Erectile dysfunction, the inability to attain or sustain an erection adequate for sexual stimulation, can be the result of age-related changes such as diminished testosterone, altered response to NO, etc. Comorbidities such as diabetes, BPH, depression, etc. And medications, alpha reductase inhibitors, beta blockers, TCAs, etc. Be sure to review these tables. So it's table 51.1 and 51.2. Before initiating treatment for ED, a physical examination and thorough medical, social, and medication histories with emphasis on cardiac disease must be taken to assess for ability to safely perform sexual activity and to assess for possible drug interactions. Diagnosis should include patient exam, including a check for signs of hypogonadism, medication review, history, and labs, such as an A1C, PSA, FLP, and testosterone. Treatment should include non-pharmacological interventions, reduce fat and cholesterol in the diet, decrease or limit alcohol consumption, eliminate tobacco use and substance abuse, weight loss if appropriate, and regular exercise. Comorbidity management, including, if possible, removal of causal medications. So if a medication is removed, consider that it probably will have to be replaced with a reasonable alternative. So table 51.1 and 51.2 he mentions again, so make sure you look at those. Examples. SSRIs are a potential cause of erectile dysfunction. A reasonable replacement or addition to offset the ED might be bupropion, assuming there are no contraindications. Dutasteride for BPH is a common cause of ED. Tadalafil is a replacement for or in combination with a 5-alpha reductase might be reasonable, assuming there are no no contraindications. Again, this is in red. Note, there are occasions where an offending medication cannot be discontinued because of a compelling indication and or lack of reasonable alternative. Example, beta blockers in heart failure, SIHD, or following an MI. One must consider if the patient is healthy enough for sexual activity. So this is table 51.3. And if so, possible alternatives such as vacuum erection devices or medications. PDE5 ones often considered drug of choice when pharmacotherapy is necessary. There is no convincing evidence that one agent in this class is superior to another. Choice may be based on patient preference, cost, and formularies. If one agent does not work, it may be reasonable to try another from the same class after an adequate trial. It is also imperative that patient is properly educated regarding onset and duration of effect. The impact of high-fat meals, the need for sexual stimulation, and an explanation that a single trial is inadequate. There is no drug effect without some type of sexual stimulation because these drugs do not cause penile erections. They only provide the ability of the penis to respond to sexual stimulation. Varying duration of action. Most is 4 to 5 hours. Tadalafil is 36 hours. Headache and flushing are the most common adverse drug reactions. Serious cardiac events are possible. Significant drug interactions exist. So this is in red. Nitrates cause severe hypotension, which we know this. In an emergent situation, a patient who has taken sildenafil may be given a nitrate after 24 hours. For tadalafil after 48 hours. Vardenafil does not have a suggested time interval, but blood pressure and heart rate did not change when the drug was taken 24 hours before nitrate administration. These suggested intervals are a direct correlation to half-life and duration of action. Prolonging of QT interval, especially vardenafil. Serious cardiovascular events have been associated with PDE5 inhibitors. Therefore, they should not be used in patients in whom sexual intercourse is inadvisable because of poor cardiac status. Testosterone replacement, low T. Again, this is in red. Testosterone replacement regimens should never be administered to men with normal serum testosterone levels or in patients with isolated erectile dysfunction as the only sign of hypogonadism. Before initiating any testosterone replacement regimen in patients 40 years and older, patients should be screened for breast cancer, benign prostatic hyperplasia, and prostate cancer. All are testosterone-dependent conditions and theoretically could be worsened by exogenous administration of testosterone. Thorough medical workup is indicated. Several medications may contribute. Cimetidine, spirolactone, and ketoconazole, etc. Several relative versus absolute contraindications to use. Absolute contraindications are breast cancer, polycythemia, prostate cancer, prostate-specific antigen greater than 40 nanogigs per milliliter or 4 micrograms per liter, or the presence of nodules, induration, or digital rectal examination, and then relative contraindications are a baseline hematocrit greater than 50%, desire for fertility, severe lower urinary tract symptoms, uncontrolled congestive heart failure, untreated obstructive sleep apnea. Alprostagil, so PGE1 analog, administered by intracavernosal injection and intraurethral inserts. Because PGs bypass many steps in the erectile cascade, they are quite effective at producing an erection, even in cases where PDE5 inhibitors cannot do so, such as neurogenic causes. It's the most invasive and low patient acceptance. It's reserved as second or third line treatment. Vacuum erection devices And then over-the-counter herbals such as yohimbine, etc. Limited evidence and they're not recommended. BPH. BPH increases urethral resistance, resulting in compensatory changes in bladder function. Obstruction-induced changes in detrusor function, including smooth muscle hypertrophy. Compounded by age-related changes in the functioning of the bladder, lead to urinary frequency, urgency, and nocturia. The most bothersome BPH-related complaints. Not all patients with LUTS have BPH, and not all men with BPH have LUTS. Diagnosis includes components such as symptom assessment, PE, and PSA. PSA is present in small quantities in the serum of men with healthy prostates, but it is often elevated in the presence of prostate cancer or other prostate disorders. PSA is not uniquely an indicator of prostate cancer, but may also detect prostatitis or BPH. PSA correlates with prostate size and can be used as a prognostic marker. Interventions: surgical, transurethral microwave thermotherapy, which is a TUMT, transurethral needle ablation, which is a TUNA, interstitial laser coagulation, ILC, transurethral resection of the prostate, which is a TURP, transurethral incision of the prostate, which is a TUIP, ablation therapy, electric or laser, and then an open prostatectomy. Interventions non-surgical is symptom indices, so basically a questionnaire and then medications. Table 52.3 is your staging of BPH. Lifestyle modification. Okay, so this is under the non-surgical. Lifestyle modification, limiting ETOH, caffeine, avoiding certain medications, which is in table 52.4, such as decongestants, androgens, etc., as well as addressing comorbidities, weight loss, etc. Watchful waiting is the most conservative approach for patients with mild symptoms or those with moderate symptoms without bother. Appropriate option for patients with mild symptoms and for many with moderate to severe symptoms if they are not bothered. Behavior modification includes restricting fluids close to bedtime, minimizing caffeine, sweetened drinks, and alcohol intake, frequent emptying of the bladder during waking hours to avoid overflow, incontinence, and urgency, and avoiding drugs that could exacerbate voiding symptoms such as antihistamines or decongestants. At each visit, assess the patient's risk of developing acute urinary retention by evaluating the patient's prostate size or using PSA as a surrogate marker of prostate enlargement. The level of symptom distress that individual men are able to tolerate is variable. Alpha blockers have a fairly rapid onset, 2 to 4 weeks, with relatively rapid symptom resolution. Durable effect is years, with AUA symptom index improving in 30 to 45%. This is in red. No effect on prostate size, PSA, or disease progression. So alpha blockers have no effect on prostate size, PSA, or disease progression. They relax smooth muscle in the bladder, neck, urethra, and prostate. new second generation, so alfuzosin, and third generation tamulosin and sildenafil agents are preferred because of uroselectivity, no need for dose titration, and limited orthostasis. Older agents also have indication for hypertension and have more CV ADRS, such as orthostasis, reflex tachycardia, etc., as alpha blockade is not selective, but rather also impacts the alpha receptors found in the vasculature, e.g., terazosin, doxazosin. Dose titration should follow the start low, go slow paradigm. Most guidelines advocate for the individual management of BPH and hypertension. Note that ACC/AHA recommend that for those with comorbidities of hypertension and BPH, each of those conditions should be treated independently based on GDMT. For those with persistent hypertension, on maximized first-line therapies, alpha blockers with vascular effects may provide benefit in terms of additional BP lowering. Alpha adrenergic antagonists, so phenobenzamine, which is dibenzyline, limited use because of tachycardia and arrhythmia; doxazin, which is Cardura; prazosin, which is Minipress; terazosin, which is Hytrin; alfuzosin, which is Uroxatrol. Functionally and clinically uroselective. Uroselectivity may be due to drug formulation which achieves higher concentration in target tissue. Does dose-related phenomenon may be lost in high doses. And then tamulosin, which is Flomax, and sildenafil, which is Rapaflo. Uroselectivity may be lost at higher doses. 5-alpha reductase inhibitors. Management of moderate to severe BPH in patients with enlarged prostate glands. Management of patients who desire medical therapy but cannot tolerate alpha-1 adrenergic antagonists and do not have predominantly irritant symptoms or concomitant erectile dysfunction. Symptoms are non-bothersome, so the delay in onset would not interfere with quality of life. Reduce prostate size and PSA and thus outlet obstruction. So 5-alpha reductase inhibitors reduce prostate size and PSA and thus outlet obstruction. They also reverse and slow disease progression. They decrease the risk of disease complications. Note, although dutasteride blocks both type 1 and type 2 isoenzymes of 5-alpha reductase, while finasteride only blocks type 2, there is not a clinically significant difference in outcomes when either is used. Their peak effects are 6 to 12 months. Effect is only durable as long as drug is continued. Prostate will return to pretreatment size or larger when or if 5-ARIs are stopped. Now this is in red. Finasteride and dutasteride reduces but does not stop the prostate from producing PSA. If PSA fails to decline by 50% after 6 to 12 months, or an increase of 0.3 nanograms per liter or more above baseline nadir level, patients should be evaluated for prostate cancer. May also indicate worsening of condition or non-compliance with a 5-reductase inhibitors. ADRs, androgen insufficiency. Their decreased libido, impotence, and ejaculatory disorder, breast tenderness, and enlargement. So PDE5Is, so tadalafil, treatment of the signs and symptoms of benign prostatic hyperplasia and plus or minus erectile dysfunction. It relaxes smooth muscle of the urethra, prostate, and bladder neck. Tadalafil may be prescribed alone or along with an A1 adrenergic antagonist and or 5A reductase inhibitor, although other phosphodiesterase type 5 inhibitors share the same mechanism of action as tadalafil and can improve the UAA symptom score. Tadalafil, which is the only PDE5I approved by the FDA for this indication, is preferred because of its long plasma half-life, which is theoretically beneficial in the management of BPH, a chronic disease. Comparable efficacy to alpha blockers for LUTs, but does not increase the flow rate or reduce PVR. The peak onset is 1 to 4 weeks. It is expensive. Adverse reactions, use with alpha blockers, antihypertensive, or substernal amounts of alcohol may lead to hypotension, headache, dizziness, flushing, back pain, malaise, and cyanopsia. Precautions in unstable angina, uncontrolled or high-risk arrhythmias, persistent hypotension, poorly controlled hypertension, or New York Heart Association Class 4 congestive heart failure. Contraindication in current use of nitrates. Combination therapy. Alpha blocker plus 5 alpha RIs. In patients with enlarged prostate gland and an elevated PSA greater than 1.4 nanograms per milliliter. Combination drug therapy with an A1 adrenergic antagonist and a 5A reductase inhibitor is more beneficial than single drug therapy. The rationale: a blocker offers immediate relief. 5A RIs reduce prostate enlargement over time. It works better for those with obstructive symptoms. May consider stopping a blocker after 6 to 12 months, but should continue in those patients with severe symptoms as long as they are responding. Alpha 5 blocker plus anticholinergic or beta 3 agonist. Beta 3 agonist. For men with low post-void residual urine volumes and irritative symptoms such as frequency or urgency that persist during treatment with alpha 5 adrenergic antagonists, combination treatment with an anticholinergic agent can be tried. Improved storage voiding parameters and frequency compared with alpha 1 adrenergic antagonist therapy alone. For patients who poorly tolerate anticholinergic adverse effects, an alternative is mirabegron. The risk of side effects: increased post-void residual urine volume, decreased maximal urinary flow rate, or acute urinary retention is low. Alpha blocker plus PDE5/1s. For men with moderate symptoms of BPH and erectile dysfunction, treatment with daily tadalafil 5 milligrams a day alone or in combination with tamsulosin 0.4 milligrams per day can be considered. Addition of PDE5-Is to alpha blockers may improve lower urinary tract symptoms. PDE5I plus 5ARIs. Addition of PDE-5I to 5ARIs can offset erectile dysfunction commonly seen with 5AR. I think that he means that to be ones. Herbals. No dietary supplement combination, phytotherapeutic agent, or other non-conventional therapy is recommended for the management of LUTs secondary to BPH. Adjunctive therapy. Uroselective anticholinergic agents, which preferentially inhibit M3 receptors such as darafenacin or sulfenacin. Place in therapy. Treatment alternatives for management of LUTs secondary to BPH in men without an elevated post-void residual and when LUTs are predominantly irritative can be added to therapy for irritative symptoms such as frequency, urgency, despite treatment with an alpha-1 adrenergic antagonist. Typically, an anticholinergic agent is added sequentially to an established alpha-1 adrenergic antagonist regimen. Prior to initiation of anticholinergic therapy, baseline PVR post-void residual urine should be assessed. Anticholinergics should be used with caution in patients with a post-void residual greater than 250 to 300 milliliters to avoid anticholinergic agent-induced acute urinary retention. Because remember, anticholinergics can't pee, can't poop, da-da-da. Ideal patient for the combination has a urinary flow rate of at least 10 milliliters and a post-void residual less than 50. ADR's precautions. M3 receptors are present on smooth muscles in the gastrointestinal tract, salivary glands, eyes, and brain. For this reason, common adverse effects include dry mouth, tachycardia, constipation, confusion, and drowsiness. Elderly patients have a high risk of cognitive impairment. Mirabegron, antagonist of the beta adrenergic receptor, relaxes the detrusor smooth muscle during the storage phase of urinary bladder fill void cycle. Its place in therapy reduces irritative voiding symptoms. It's an alternative to an anticholinergic agent in patients who poorly tolerate or at high risk of anticholinergic adverse effects, or when irritative voiding symptoms do not respond to an anticholinergic agent. Not Food and Drug Administration, FDA, approved for this indication. Typically added to an A1 adrenergic antagonist. ADRs, headache, so adverse drug reactions, headache, hypertension, tachycardia, constipation, and nasopharyngitis. And that is the end of our men's notes. Good luck.